So I'd like to welcome the panel presentation by the International Paruresis Association. My name is Laura Johnson, and I'm a board member from Silicon Valley, San Jose, and I'll be hosting today's session. I'm admitting a couple more folks. So we're honored today to have 3 current and past board members with us today from the IPA. Steve Soifer, Dan Rocker, and Ruth Lippin, as well as Tim Pyle, the executive director. Thank you to everyone for joining. So we are recording the presentation and it will be posted on the NSAC website. The IPA will also post it on their website. Yep. So I'd like to introduce our speakers. So Dr. Stephen Soifer, PhD, SW, and he is the co-founder, senior consultant to the International Paruresis Association. He is I'm admitting a few more people. He is the primary author of The Secret Social Phobia, Shy Bladder Syndrome, Paruresis, and it's the best-selling book on the condition. His book has been translated into Chinese, German, Spanish, and French, as well as other languages, and it's being in the process. He's also the co-founder and president of the American Restroom Association. We also have Dan Rocker, LCSW/R, and he's a therapist whose private practice is in New York City, and it focuses on treating paruresis as well as providing individual and family therapy. He has lived experience with the disorder of paruresis. Dan is the president of the IPA and has been a board member for the past 9 years. His first career was in finance, and when not working with clients, he's enjoying time with his family and he enjoys bicycling. Then we have Ruth Lippin, LCSW, and she's also an attorney, so a JD. She's a licensed clinical social worker that has private practice in New York City for the past 20 years. She specializes in the treatment of anxiety disorders, OCD, and other mood disorders. For the past several years, she served on the advisory board of the IPA and the board of directors of the New York City CBT Association. Prior to becoming a cognitive behavior therapist, she had a successful career as a public interest attorney in New York City. Okay, let's get started with the presentation. Then we have time for questions and answers at the end.
Okay, all right. Good morning. Okay. I see that by putting that screen up, that basically blocked my access to my notes. But that's all right because I have a backup copy. So good morning, National Social Anxiety Association or National Social Anxiety Centers. Let's talk paruresis. Paruresis is more commonly known as shy bladder or pee-shy or stage fright. And it is the inability to urinate in public accommodations for psychological rather than for some kind of organic physical cause. Now, most therapists have not seen a lot of paruresis cases, if they have seen any at all. My own psychoanalyst, who's been in practice for 40 years and who I've seen for the last 15, has told me that before meeting me, he had never heard of paruresis, nor had he ever heard about the symptom. This is a fairly ubiquitous response amongst the therapists that I know here in New York City. As it turns out, there's no real shock here. Most patients seldom discuss their toileting behavior with their therapist. And just anecdotally, I'm a member of a peer supervision group in which I'm the youngest person and the only male, the youngest person by about 30 years. And when I first presented in order to get into this group, the women told me, this is fascinating. We've never heard about this. And we've never seen a client with this. And I pointed out to them, I said, you've actually probably seen hundreds of clients with this. It's just that they were coming to see you for something else. And so you didn't interview around this topic. But I'm sure if you did, you would have turned up some paruresis clients because they're just not that few. I should say, we are not that rare. Okay. So I began with this very short definition of paruresis, the inability to urinate in public restrooms because of psychological rather than physiologic reasons. But now I want to create a more vivid picture for you of what paruresis looks like out of the DSM-5 and in bathrooms and around the world, and how it may present in your office. So in order to facilitate that, Tim's going to show you two quick video clips that I kind of stitched together, or he actually really stitched together, from current American TV shows that illustrate two facets of paruresis as it is most commonly being enacted. They say a picture is worth 1,000 words, so I've got to figure that this video is worth roughly 1,000,000 words. And within the next 90 seconds, you will all be experts on paruresis, and particularly the distinction between primary and secondary paruresis. Now, these clips are both from immensely popular shows, I want to add. They're from HBO's Succession and from Fox's Family Guy. And each clip portrays a seemingly identical event. Two men enter a men's room together and approach the urinals with the goal of urinating, or at least the stated goal of urinating. And in both cases, one of the main characters can't urinate. So Tim, could you please run the Vimeo video? There we go.
Why don't we just, like, take a big old piss on our app? I'm going to open up the app on my phone, and we can stream some piss on our little streaming platform. How's that sound?
19, 20, 21, 22.
Yeah. So, I can't piss near other men due to we don't know what reason, but please, go ahead.
Don't mind if I do.
Man, enjoy.
Oh, cool. 2 spots opened up.
You go ahead. I can wait. I might wait for a stall.
Oh, come on, Peter. We're missing the game.
Hi.
Hey.
Damn it. You already started. If I don't start peeing soon, it's gonna be weird. He'll be all done and I'll still be here. Come on, Peter. Pee. Your dad fought in World War II and you can't even pee in a urinal. What the hell's wrong with you?
All set?
Yep.
I know you didn't go.
I'm gonna go pee in a stairwell.
Okay, so these two videos portray people with paruresis, and I want to point out that people with paruresis tend to defend themselves from the anxiety and discomfort of paruresis through avoidances, ranging from fairly benign ones, such as for males sitting on a toilet, which is something that Peter was trying to do in the video, or by running the faucet to cover up the sounds, or more importantly, for people with paruresis, the accumulating silence, to cover that up with the sound of the water running. And these avoidances, they tend to expand until there are some fairly serious and lifestyle limiting avoidances that appear, like fluid restriction, social isolation, and curtailment of professional, travel, or recreational opportunities. Paruresis is also almost always associated with significant anticipatory anxiety, as well as the situational anxiety in restrooms. So, but back to the video clips for just a moment. I hope people are able to clock the difference, or at least notice some of the important differences between the first and the second clip. In the first clip, Roman Roy just announces his debility, and he makes no excuses for it. Peter, in the second clip, has a horrifying, punishing internal monologue, which we get to hear, as he desperately tries to seem normal before admitting that he's misfired and is going to have to find a dumpster or a stairwell to go pee down. So in a nutshell, these two scenes highlight two important facets of paruresis. Comparing these two scenes and contrasting them illustrates the difference between primary and secondary paruresis. In both scenes, the protagonist can't pee because of the presence of another person. This is primary paruresis. It is the symptom itself. It's a psychologically based functional inhibition from urinating. Roman can't pee in front of Matson, Peter can't pee in front of Quagmire and all those other Red Sox fans. But now let's think about how these two scenes differ from each other. Roman, in the first scene, doesn't even endeavor to urinate, explaining, so I can't piss next to other men due to, we don't know what reason, but please go ahead. He is seemingly untroubled by his revelation. In fact, the only reason that Roman and Mattson are in the bathroom together is because it was Roman's idea as a stunt, to build affinity with this guy by allowing him to piss on the cell phone that represented the product that he was selling. So he's the one who suggested it. It is hardly avoidance behavior. If anything, it's approach behavior. On the other hand, in the second clip, Peter Griffin, experiencing the exact same symptom, is deeply ashamed, as his internal monologue reveals. Come on, Peter, pee. Your dad fought in World War II and you can't even pee in a urinal? What the hell is wrong with you? This shows that not only is Peter affected by primary paruresis, the urinary inhibition itself, but also by secondary paruresis, which we can define as all the negative thoughts, feelings, self-appraisal, and shame that tend to accrue to having the symptom of paruresis. Unlike Roman suggesting a trip to the men's room, Peter deploys 3 types of avoidance in a 30-second clip. First, he suggests that he might wait for a stall. Second, he pantomimes or pretends to urinate. He zips up and zips down. And third, he decides to engage in the ultimate avoidance by saying he's going to wander down a stairwell to urinate alone. So when I encounter paruresis patients in my practice, most I find are going to present with a very high degree of secondary paruresis as well as the primary. In fact, anecdotally, outside of my practice, I'm very open about this. I talk about paruresis with just about everyone I meet. I probably bore people, but I've encountered plenty of people and talking to them about it who meet the criteria for primary paruresis, but they don't care about it. They'll say something like, "Oh, that's the way I've always been," or "I've always just been a stall guy." So this calls to mind the maxim of the Stoic philosopher Epictetus. I don't know if people are aware, but the Stoics have been having quite a surge in popularity, lately. I mean, it took, I guess, a nice long 2,500-year build, but boy, they're really hot now. And it calls to mind a maxim of Epictetus's, which is, it is not events that disturb people, it is their judgments concerning them. My clients, particularly if they are male clients, and Ruth can address some of the differences when she's speaking, they commonly have some pretty tough self-judgments and shame about not being able to pee around other guys, which society has determined is customary or normal for them. So now that I've given a brief description or definition of our terms, I'm going to step back a little bit and let Steve provide a broader overview of paruresis, where it lives in the DSM-5, and how we look to approach treatment in the IPA.
Yeah, and you got to turn your volume down. Dan and I are doing this from his place, even though the backgrounds look different. And I just want to say hi to Larry and John, who are on, who some may know are part of our Shy Bladder Center. And actually, if I remember correctly, at one point in the last decade or two, co-led a workshop with me for people with paruresis, and hence have worked with clients who have this disorder. So in terms of an overview of paruresis, it's important to realize that it's actually now mentioned in the DSM-5. We worked hard to at least get an example of paruresis mentioned there. It falls under the DSM-5 300.23 category of social anxiety disorder. And I believe, and maybe Dan can correct me if I'm wrong, that the ICD code for social phobia is F40.10. Okay, thank you. But they don't mention, at least I didn't see it mentioned in the law, in the current edition of the ICD. So we know it's a social phobia. It's not the purpose of this workshop to go into the fact that it's more than a social phobia because it involves physiological processes. But suffice it to say that almost all the clients you see, that the primary problem is going to be the social anxiety surrounding the inability to urinate in public. We know that we can easily help people who have this social phobia with CBT. I mean, CBT, as you all know, because you practice it, has shown to be effective for most phobias, and paruresis is no exception. And usually in one-to-one sessions over 8 to 12 times meeting with a client, a live weekend workshop, which is sort of roughly equivalent to 8 to 12 sessions, and ongoing support groups that we have in many places across the US and actually across the world. People are significantly helped by this disorder. I want to be clear that this does not mean that they're cured of it. And paruresis doesn't seem to work like that. Be interesting to compare it to other phobias, but it doesn't appear in almost all cases to be fully extinguished. It seems to be what we would call in remission, which is why we generally speak about recovery rather than cure when we work with people with paruresis. Next slide. Oh,
yep.
Now I'm going to turn it over to my colleague Ruth to talk about differences between men and women.
Okay, so I became one of the female voices of paruresis many, many years ago when I started practicing as a CBT therapist, and one of my early clients walked in and said, I can't pee in public bathrooms. And so I somehow found Steve's name. I called him up, and the rest is history. So if paruresis is the secret phobia that's still 20 years behind where other phobias are in terms of people understanding them and knowing about them, women are the unknown sufferers of paruresis. There has not been any studies as to the ratio of men and women that have paruresis, but anecdotally, it seems that not as many women suffer from paruresis as men do. And it's not very well understood. Some of the thoughts that we've come up with is that women always use stalls, and more importantly, that women's paruresis, at least secondary paruresis, in terms of what Dan was talking about, in terms of people judging themselves harshly, is not associated with issues of masculinity the way it is with men. So it doesn't take on that whole other meaning. Okay, next slide, please. So I'm going to tell you about one woman that I've worked with to highlight how enormously disabling this phobia can be from both a developmental and social perspective. So I had a 20-year-old woman come to me who wanted to go away to college. All her friends were going away to college. And by the way, this is not an unfamiliar theme. I just had a woman call me yesterday telling me that she had gotten into a college away from home, and at the last minute, she panicked, Her mother panicked, and she's now at a local community college. I have told her we are getting her back to that college that's a few hours away next year. So this woman also could not go away to school. And in fact, she could not even live in the dorms at the local school. She had significant social anxiety, and typical of a lot of parents, because they don't know what to do. There's a lot of parental accommodation with this disorder of parents, instead of sort of pushing to find a more developmentally appropriate solution, want to keep their kids at home. She came to me, luckily, because it's all about finding the right motivation to get people to work on this, because she was in her third year of college and there was a trip to Ireland. And a lot of her friends were going. She had already, she had originally signed up for the trip, but had, again, in sort of a fit of fear, with her mother's encouraging, had then resigned from the trip. So I went to her. So we had like 3 or 4 months to work on this, which was perfect. I mean, sometimes, it's too late and we can't work on it. And anyway, so the good news is, I'll fast forward to the end of the story. She did end up going to Ireland. She had a fabulous time. She came back and she told me she signed up for 3 other school trips for her senior year abroad. But how did we get her there? Well, of course, we did the behavioral approach of practicing going to bathrooms using a hierarchy. But more importantly than that, we also really spent a lot of time talking about her self-judgments, as Dan was talking about. And then, in addition to this, and am I talking about this right after this? In addition to this, she also was actually in nursing school, and she was willing to learn how to self-catheterize. And if you get a client that's willing to self-catheterize and use it as a safety net, it truly is a game changer. So, and she did have to use it once when she was in Ireland, but only once. And, I'm happy to report that, I spoke to her a few months ago, and she's just doing fabulous. So what are women with paruresis afraid of? Well, they're afraid of being judged. Paruresis is a social anxiety, and at least in women, because I think Dan had said he doesn't see this as much, I would say anecdotally that most of my female clients suffer from other forms of social anxiety. And we simultaneously work on those other forms of social anxiety while we're working on the paruresis. One of the main things that they fear is that they're going to be inconveniencing people, right? So if there's a line and they have to make people wait too long. And then, as with men, they're afraid people are going to judge them about the stream. Their stream is too strong, it's too soft, it's intermittent. And in addition to that, they also have a hypersensitivity to bladder sensations. So one of the ways we work on that is I have them fluid load in a safe environment and have them purposely not go to the bathroom for some period of time. Okay, next slide. I touched on this a little, and Dan has also touched on this. One of the main issues with people that have secondary paruresis is the shame that they experience. So if you are Roman on Succession, you're cool because you don't have any of that shame and you'll just proudly walk into the stall. However, if you're like most people with social anxiety and have multiple fears about being judged, that's where it becomes a problem. So one of the first things I do is I ask them, who knows about this? And you would be amazed. I actually just started treating somebody last week. He's been married for 11 years. His wife barely knows about it. And I said, oh, did you tell her you were coming to see me? And he said, yes, but he did it in a very sort of offhanded way. So his first homework assignment was going home and talking to his wife in a meaningful way about what it meant to have paruresis. So we really make a list. Who might be a supportive person to tell? And there can be a dramatic decrease in the paruresis just from doing that. It's a biological condition. It's not their fault. You can often trace strong family histories of this, often family histories that haven't been talked about until they finally ask. And they'll be like, oh yeah, your grandmother, she always, went to the bathroom, far away from where we were. So you can also, I really talk a lot about how it is biological. And I talked to them about how the definition of bravery is doing something despite fear, right? It's not bungee jumping if you have no fear. It's going to a public urinal, with fear. And then, of course, I love to do Steve's favorite way of trying to reduce the shame, which is that we're only talking about a muscle, right? We're not talking about what type of person you are, if you're kind and joyful and giving. So I try to work on it those ways. And I think, is there anything else on mine? Self-catheterization. Okay. I am such a fan of self-catheterization for both men and women. I think I may be more of a fan of it than Dan and Steve, although you'll have to ask them. It's the Valium you carry around and never use. So, and I have seen it really take this from being a disorder to not being a disorder. And Carol Olmort, who wrote the book on female paruresis, I would say that was a significant part of her recovery. It's a hard sell, but when you can make it happen, it makes a fundamental difference. Okay, so now we're going to talk about differential diagnosis. And I think, Dan, that's you're back on. I can't hear you.
And Dan, you're muted.
Okay.
Dan is muted.
Okay. All right. People hear me now, I imagine.
Yes.
When I took the mute off, that was helpful. Okay. All right. So at the outset of treatment, even with my younger clients, where it's really very low likelihood that there's any kind of lower urinary tract symptom, I would still prefer that they at least talk to their GP or a urologist about it, just to get an extra set of eyes on their situation to make sure that they have confidence that they don't have an organic problem and they can proceed with behavioral, with CBT and work on it. Now, the problem is, if you send your client to a urologist, in most likelihood, that urologist is not going to be particularly sensitive to psychological factors. And in my experience, almost everyone who goes to see a urologist, in the absence of, first they'll do some invasive tests, they'll do a cystoscopy, maybe a video urodynamic survey, of course, a digital rectal exam for males. And with no findings, they will come up with two prescriptions. They will say, well, it's probably a bladder neck issue, so you can take, these alpha agonists or something, these kind of medications that tend to loosen up your bladder neck. And they're also probably going to issue a prescription or write up a script for pelvic floor physical therapy, because they'll say, well, since there's nothing wrong with the bladder that I can see, it must be a problem with the musculature of the pelvic floor. And there's nothing wrong with going and getting pelvic floor physical therapy. It's just that it's expensive and it's not going to touch the paruresis. I can tell you this from personal experience. Everything that I'm mentioning here, I've gone through all the stations of the cross myself. And so actually just last week, I addressed a group of pelvic floor physical therapists down in Virginia. They and I share a case. And so I did a little teach-in to them over lunch. And, I said, you're probably familiar with these ideas of rule outs. Well, if it's It might look like depression, but we're going to have to investigate to see if there's a recent loss, in which case it's not really depression. Okay, so that would be a rule out for depression. What I've come up with for paruresis is the one question rule in, which is right there on your screen. You know, if your client is reporting that they have situational difficulties with urinating, not global problems with urinating, you could just ask them, do you ever have this problem when you're at home, when you're alone, and when there's no time pressure? And if the answer is yes, we'll send them back to the urologist, because, you know, if they're having this problem, the way I like to explain it is I say, listen, this is a social phobia. If you're at home alone and under no time pressure, there's not even a hypothesized society that you're responding to. So, you know, in that case, I would send them back to the urologist for another look-see. But if the answer is no, well, if I'm at home, there's no time pressure, I know my wife's out of town for the weekend, you know, I pee completely normally, well, then presto changeo, you know, you have probably just assessed that paruresis is the probable culprit. Am I in the next slide, Tim, or let's see. Oh, yeah. So the common mental health comorbidities, I don't need to dwell on this. You know, it's just, you're going to see, if there's a Venn diagram, you're going to see, I should say, a lot of overlap between my patients for paruresis that also might have a tentacle in the generalized anxiety disorder world and a root in the obsessive compulsive disorder world. It kind of looks like OCD in some respects. I've actually had, you know, conversations back and forth with Carl Robbins over and over. Are you sure there's not an OCD component with this? But he's beating it out of me. It's not OCD. You know, social anxiety, generalized, of course, substance use disorder, persistent depressive disorder, major depressive disorder. The reason I throw these in here is because substance use disorders frequently are secondary, not secondary paruresis, but secondary to having a very significant anxiety disorder that's impairing, you know, your feelings about yourself and your life. And so you start to self-medicate. And, you know, the way I was taught, this very rudimentary way of looking at the difference between anxiety and depression when I was going through psychoanalytic training was that the depression's largely retrospective, and anxiety is normally a concern about the future. You know, I don't really buy that anymore. I kind of think that if you're anxious enough, it's going to start to make you depressed. But anyone wants to pick a bone with that could go ahead and talk to me about that later. You want to go to the next slide, Tim? I'm not sure. Is it me on the next one? No. Oh, no, it's it. Hold on. Let me get the mute on and volume down.
Yeah, can you hear me? I'm on, good. I just want to segue from what Dan said, and it's important to realize that paruresis can actually cause some of those other conditions. It can cause substance abuse, it can cause depression. And so, and sometimes if the client doesn't reveal what's behind that, it gets pretty complicated. You know, it can be mistaken for agoraphobia. You know, the client never goes out. Why don't they ever go out? Well, they can't piss, you know, in public. that's a major deterrent to going out and traveling and all those things. So it's just important to keep that in mind, the causality. So, you know, we over the years have contributed to the research on paruresis, you know, prior to my getting involved 25 years ago with this. There was literature, and it's summarized in the book, The Secret Social Phobia, but there was very little research done on the topic. So we have done, it's hard to know, but it's probably approaching close to 200 workshops. Not all myself, I've done over 100, I know that. But we did analyze the data from workshops in two studies. The first one, we looked at our workshops from 1997 to 2003. We had 100+ participants compared. Now, some people really get off on this stuff and other people don't. So I'm glossing over this, just want to be clear. Compared pre-test, post-test, 1-year follow-up ran statistical tests. And what we came up with is that there were significant improvements in people's global severity symptoms of paruresis, both at post-test and 1-year follow-up. However, big caveat, there have been no gold standard tests, meaning we did not have control groups with this, and that's extremely important. I'm sure everyone knows that. So all we can say really is that we think workshops are helpful to people who have paruresis. Dan and I and Ruth, when she's participated, and others have all seen it, but it still does not meet that litmus test. Next slide. So then we did a second series of analyses on our workshops from 2004 to 2019. This is when workshops stopped for a couple of years because of a little thing called COVID. We had over 300 participants in this data analysis. You know, you can see the imbalance between males and females. Participants on average were about 43 years old, have had paruresis for 27 years, with the majority not knowing the cause, which coincides with Dan's and mine, and I think Ruth's experience, that half the people seem to remember an incident that caused their paruresis and half don't, but ultimately it's irrelevant. In this study, we only were able to compare pre and post test. We didn't have any follow-up data. We ran a variety of statistical tests. And it's just important to realize in what I present next that there are major limitations on this study, also on the previous one. Remember, this is all self-reported data. Again, no control group. And the effect size is weak, unfortunately. So next slide. Oh, I'm gonna have to minimize this. Hold on. So bottom line, and unfortunately, Tim, I can't read the bottom of my screen. Is there anything that can be done about that? Let me see if I can enlarge this. Hold on. Oh, disappeared again. I don't know if people can see this. I can't. But the results of the tests we wrote ran. And I want to thank my wife, who is also Dr. Soifer and has a minor in statistics, for helping out with the data analysis. So essentially, we see that the severity of paruresis pre and post test is significantly different. And I believe, without being able to see the bottom, that there was significant improvement. Again, pre and post test, meaning from before the workshop to after the workshop, in how severe people felt their paruresis was, meaning that there was a significant improvement. Next slide, Tim. Okay, I cannot see the bottom of the slide, Tim. Is there anything that can be done with them?
So you mean the bottom piece, participants were less anxious about the sounds made when using a bathroom after a weekly workshop? That
okay.
In yellow?
So two of the interesting effects from the workshop is that people felt less anxious about people seeing them or hearing them go to the bathroom. So those are two secondary paruresis signs that seem to have improved during the workshops. And we also saw, next slide, Tim. Sorry. and now the next slide, that the so people's being open about this condition, in other words, the secrecy aspect of it, surprisingly didn't seem to affect the results, whether they had told no one or had told everyone. There was a gender difference, but remember the size effect. We only had 10 women, but men seemed to improve more than women. And also surprisingly, from this data, apparently how long someone had the condition didn't influence the results from the workshop. So if you had the symptom for 5 years or 50 years, didn't impact the results of the workshop. Next slide, and I think, yeah. So now we're back to debate.
That's me.
Let me move.
So these are just
I have to.
You turn the volume down. Great. These are just a list that should be familiar to all of you, the modalities and the techniques that I have to imagine you're all already using for all the anxiety disorders you're treating. For the primary paruresis, you're basically doing exposure-based work. We create a desensitization hierarchy. I literally just got back from the LA workshop at 2 a.m. So this is topmost in mind. We create a 10-step ladder, and people, create a baseline, which they're 95% sure they can currently execute. And then they gradually, move higher and higher up their hierarchies. And in real life workshops that we run, they're able to do it with other people, which is great. And so this is the exposure-based work, largely to treat the primary. For the secondary paruresis, cognitive behavioral therapy, acceptance and commitment therapy as well, telling people, teaching them about actually what happens. I use the work of Sally Winston and Marty Seif to kind of, show what's actually happening in your brain between the first fear and the second fear. And also, talk about Russ Harris's work and how not to just basically try to not engage and pull the struggle switch. And then, of course, the coping skills kind of training that Ruth was just talking about, intermittent clean self-cath for both males or females. And then, so Ruth was saying that she might like catheters better than I do. If you include the Stadium Pal, I am a big booster of the Stadium Pal, which is, or Stadium Gal, as I put here, right? Okay, which is in fact an external catheter. So it is for males at least, a condom catheter. And so there is, I think it's kind of hard, particularly for my male clients who are say in their 20s. When I start talking about catheters, it's a hard sell, as Ruth said, would be an understatement. I can't sell it. But putting on a condom catheter, I mean, most of them have used a condom recently and have some familiarity that it's not something that's going to potentially permanently damage them. The breath hold technique is something that never really worked for me, but for, say, apparently 10 to 15% of the people who do have paruresis, if you hold your breath literally until the point where it feels like you're going to pass out because of some kind of increase in carbon dioxide concentration in the blood, apparently this causes some release of the pelvic floor muscles. I have not experienced this to be the case, but some people do. And so I just include it because it's, we are the IPA, we have put out a video about this. It's probably the most popular video we put out. It's got almost 4,000 views of people trying to find a silver bullet. It's obviously also free. Everyone can control their breath by themselves without, finding a therapist. And then, of course, the medications, the selective serotonin reuptake inhibitors and benzodiazepines, as needed and only situationally tend to be the medications that are prescribed most frequently for this. None of them are, of course, magic bullets, and none of them, if anything, the SSRIs may reduce background anxiety to the degree and to the level that people feel that they now can engage in practice. Is next slide me? I'm not even sure what's next. Oh, is this you, Steve? The advocacy?
Yes.
Oh, let's do this.
Go ahead. Everyone hear me?
Mhm.
So one of the issues that we face for people with paruresis, and this literally was true from day one when we started the organization over 25 years ago, are people who try or are required actually to do urine tests for work and are unable to provide a sample. So we have been advocating for 25+1 years to change the Department of Transportation rules regarding urine testing. And basically, it's very simple. We have argued that people who are unable to provide a urine sample, as opposed to being fired from their job, which has happened quite a few times, be allowed to simply do an oral fluid test, saliva. And after many, many years, and it's not just us, but you can imagine the oral fluid people, those in that industry, which is minute compared to the urine drug testing industry, which is a multi-billion-dollar industry. We have somewhat prevailed in this argument to the point that the federal government, at least, is now going to allow employers the option of giving their employees the ability to use an oral fluid test. The big rub here is it's the employer and not the employee who control this decision. So we're waiting for these new rules to come out to see how flexible or how inflexible they're going to be regarding employees' ability to use an oral fluid test. There's also hair sampling, that's in the stages of being approved and probably will ultimately be another way of testing for drug use. But unlike Europe and Asia, where, I give workshops and mostly this is a non-issue for people. In the US, as you all know, starting in 1980, this became a major push by employers and the urine drug testing companies. So stay tuned for that one. We're still waiting. Tim, our executive director, has told me that we should know soon, maybe even by the end of the year, what the DOT's ruling on this is going to be and why this is so important. Most people aren't aware of this, is that the DOT, Department of Transportation, sets the standard for private industry as well. And so whatever the DOT rules is what private industry is also going to adopt. Next slide. Oh my gosh, we're finished. We're into the question and answers.
Okay, thank you.
Tim, do you want to just step in for a minute, introduce yourself, and also tell us about the last slide?
So I'm the executive director of the International Paruresis Association, and I get 10 inquiries a week from people all over the world who are looking for help, and I'm happy to coordinate. If down the road you have any questions or you're looking for some more resources, please reach out to me, tim@paruresis.org. So yeah, so it'd be great if you have any questions for the team.
It looks like Larry has a question.
Yeah. First of all, it was a very powerful experience, the one weekend workshop that you guys lead, that I participated in Baltimore at some point before the pandemic several years ago. And since then, and through your website, I've gotten several referrals, and I wanted to share with you a somewhat different perspective that I don't know is right. So it's my thought, but I wanted to get your feedback on it. What you're describing, and this is to all of you, as the difference between primary and secondary paruresis, to me, I see as all part of one thing. And maybe it's because I come from a CBT for social anxiety perspective. But the idea that having shame-based or anxiety-based self-critical thoughts, as well as presuming that other people are having judging thoughts about you for being having difficulty urinating in some sort of public setting, to me is not the secondary result of paruresis alone, although it may be in part, but it's also part of the cause of paruresis. That it's a, it's a chicken and egg argument, I suppose, which came first, but I would argue that it's circular, that negative thoughts about other people's judgments or shame-based thoughts, which are essentially self-judging thoughts, create tension, including in the muscle that you want to be relaxed in order to urinate. And so that's part of what is causing social anxiety in general, including paruresis, which is why the CBT, the cognitive aspects of treatment, I think are really important. And the examples given of people that don't have shame-based thoughts, because, in one example, because they, for men anyways, go to the stall all the time, even though they may only need to use a urinal, is to me roughly parallel to a socially anxious person in a social situation saying, oh, I don't feel bad about myself. I just hate parties. I never go to settings to mingle. Well, fine. Avoidance does reduce anxiety, but that doesn't mean it's a different disorder. It just means they've relied heavily on a safety behavior. So I just wanted to share that that's the way I view it, but I don't know if you guys have vastly more experience. I'm curious your reaction.
You want to turn that down for a second? So actually, I'll give you another example, Larry, and see if your comments apply just as strongly to this particular example, and then we can reassess. So the anecdote I love charging out at all these workshops is, when I was in college, I lived on an all-male hall in a dorm. There was obviously a men's room, and my best friend at the time, still my best friend, is a guitarist, and he used to like to play the guitar in the bathroom for the acoustics for some reason. I don't understand, but so I would frequently be in the bathroom with my best friend talking to him just while he practiced. And if I ever had to go to the bathroom, I would make some excuse, and then I'd run to some other bathroom and then come back to the bathroom that we had been talking in. And on one day in question, a third member of our hall walked in, and he saw us, and he just said, "Hey, Marsh, hey, Dan." Oh, okay, that's his name. Would you guys just step out of the hall for a sec? Because I have a shy bladder, and there's no way I'm going to be able to pee with you guys just standing there. And so my guitarist friend walks out in the hall and just shrugs. And if you remember the old Looney Tunes cartoons, you can create a mental image of like gears grinding and a steam whistle blowing out of someone's head. I was thinking, shy bladder, the hell is that? Like, that must be what I have. How come Dougie can say that? I guess that's his name, and I can't. And the reason was, as I conceptualize it, that at that time there were two people with paruresis in the bathroom, but only one of them had secondary paruresis. The first person who I just described, who asked for the minimal accommodation, he had the primary in spades. He knew he would not be able to urinate with us there. I, on the other hand, was in the exact same boat, but at the same time, I had such negative, had such shame about it that I couldn't even discuss it with this guy. And even though we were close friends. So, does that shed a little more light? I think that, so truly it's not just like, it's a preference or whatever. He just, he was every bit as affected as I was, to the best of my ability to discern. I'm not in his head. I don't know his experience. But he seemingly just had no shame asking for the very minimal accommodation. Am I getting at a little bit about what you're asking about, Larry, or did I miss it?
Well, I hear what you're saying. To me, that's roughly similar to a socially anxious friend telling another friend with whom they're going to a party, "I'm just awful at talking to strangers. I'm going to stay by your side the whole time."
Mm-hmm.
it's a safety seeking behavior. It helps them. Safety seeking behaviors typically do help in the short run, but what they don't do is overcome the problem.
So that's why I think we draw the distinction between, you want to mute that? Yeah. That's why I think we draw the distinction between, okay, the graduated exposure is going to be what we're doing to work on the primary, and all the other stuff, the acceptance and commitment piece, or maybe a mindfulness piece or a self-compassion piece based on Chris Germer's work or Kristen Neff's work, that we're going to be using to work on the secondary. Again, am I getting a little closer? Or?
Yeah, we probably are just about out of time, but if somebody has one question or so, maybe we can take one more. Okay, well, I have a quick
I will just say, I think, Larry, you're really hitting on a fundamental question about, what is paruresis and what causes it, and is it, primarily physiological, or is it primarily cognitive? So I think that's a big question that has really not been answered.
And let me leave you with this, Larry. We have a board member who had his prostate removed and was functionally cured of paruresis, meaning he no longer had the symptoms of not being able to pee around other people, yet still had the secondary paruresis, meaning he was wondering, he was nervous, he was anxious, all the thoughts that he had prior, the secondary paruresis were still there. The only difference is he was able to pee next to other people. So ponder that one. No, I don't think so.
Okay.
We're out of time.
Okay, so we're out of time, but I'm going to send everybody the emails for the presenters. And then if you have additional questions, you can send them by email. Then I want to thank Steve, Dan, and Ruth for such an informative presentation, and also for Tim for helping behind the scenes. Thank you, everyone, and have a great rest of your week.
Okay, thanks.
Thank you.
Bye.
Bye-bye.